BodyWisePerfectSize.com is pleased to bring you an interview with Dr. Lucy Aprhamor, a registered dietitian, an internationally recognized authority in the field on size discrimination and weight stigma, and co-author on Body Respect, What Conventional Health Gets Wrong, Leaves Out, and Just Plain Fails to Understand. Lucy, you have a particularly powerful document on your website about health at every size myths. It's one of those documents that I think everybody should read. One of the many things you talk about is research that you've done into diabetes and weight.
There is a link between type 2 diabetes and fatness, and it's commonly been taught that that means that becoming fat causes type 2 diabetes. In fact, what we know is that the main metabolic dysregulation of diabetes is insulin resistance. And when somebody is insulin resistant, they will experience weight gain. So we can see that the pathway, there is an association, but an association is not the same as a causation necessarily. And the pathway here seems to be going from insulin resistance to weight gain. Now, that's one thing to be aware of. And the other is, I also sort of want to say, well, so what? Because there's so deeply entrenched an assumption that if people put on weight, it is necessarily pathological. And that's not always the case. There's an awful lot of research that shows that people in an overweight category have better longevity than people in a normal weight category. That's Catherine Flagel's work, and it's been repeated, shown many times with huge numbers of people. So I think with diabetes as well, what happens is that the focus on weight misses the fact that diabetes is increasingly being understood as a disease of disadvantage and depression. That's not to say that eating well and looking after ourselves and keeping active won't impact quality of life. They will. So it's always looking, yes, absolutely, let's put compassionate self-care in there. But if we want to prevent diabetes at a global level, then we need to build equitable societies. That I will frequently work with people who have diabetes, who feel very guilty for their condition. And we need to get the message out there that that this is not, whether or not we get a metabolic condition, does not boil down to our lifestyle choices.
Talking about choices, one of the things that fat people don't have a choice about is how much stigmatization they have to put up with.
There's research on what we might think of as a sort of biochemistry of discrimination. And we know that people who live stressful lives tend to have greater circulating levels of cortisol, which is the chief stress hormone. And the cortisol, when it's consistently elevated, then leads to other metabolic changes that predispose people to heart problems through things like increased fibrinogen, which leads to blood stickiness, which leads to thrombosis. So there's certainly very, very plausible biological pathways that can be traced.
Lucy, what's the difference then for the body between long-term discrimination and, let's say, just a stressful event?
When somebody has a stressful experience, all things being equal, the body responds to the stress and then goes back to its baseline sort of regulatory levels, and that process is called homeostasis. When somebody lives with chronic stress, it's no longer possible for the body to revert to the baseline homeostasis, and it enters a state of sort of ongoing metabolic dysregulation known as allostasis. There's plenty of work in the literature that simply hasn't made its way into work that focuses more particularly on a lifestyle agenda.
Lucy, can we talk a little bit about vocabulary and how it's used in the area of weight and health?
You can change the vocabulary around something without actually changing the intent behind it. And that's not to underestimate the power of vocabulary. I think it's hugely important. For example, the way that terms around weight so often devalue fatter people and also make assumptions around their health that are simply not valid.
It seems to me, Lucy, that one of the biggest ogres is the whole idea of a diet mentality.
If we're judging food in terms of good and bad, this black-white sort of all or nothing thinking, that when we judge foods in terms of healthy, unhealthy, good and bad, and we judge ourselves in terms of good or bad depending on our weight, then we learn to live in a way and we learn to think in a way where judgment becomes our default position. And that's a very, very harsh place and to go through our day with. So the diet mentality thinking because it leads us to think in this black and white, the so-called binaries. I think it also takes us into shame and disconnect, because there's no middle ground. Either I'm perfect or I'm useless. There's an alternative to this very rigid way of thinking that leads to competition, leads me to assess my body in terms of other people's bodies, and also leads to a body-mind disconnect. When we lose access to our emotions because we're focusing just on logic, then we've got less to guide us in how we grow in the world.
Lucy, people that are overweight often get blamed when they can't breathe, and I was wondering, I know you've done some research into that, what you found.
Again, it's very interesting because it's often misrepresented. The research that I've looked at shows that patients with COPD, which is chronic obstructive pulmonary disease, that there's a lot of advice out there that says if your BMI is over this, then you should lose weight. And when I've actually followed it to the papers that are cited, the papers cited don't support that conclusion. And in fact, the best available evidence that I found showed that people up to BMI of 30 to 35 actually had better outcomes. And the authors pointed out that the cutoff was 35 because they didn't have sufficient people in the BMI group above that to make any statistically significant claims. And the way that I would tend to talk about it, it's really important to keep your strength up, because of course if somebody's got lung problems and they lose weight, they're also losing muscle mass from the lungs, and that's not going to help them their breathing. But the metaphor of fatness as being an absolute dead weight that's impeding hearts, impeding lungs, that's what we need to start challenging.
Lucy, what are some of the problems that fat people with joint problems experience?
If I went to the doctor at my weight, then I'd expect to get taken seriously. I'd expect to get my medical history taken. Maybe I'd be given some painkillers. I'd be given a referral for some physiotherapy. And I would come out feeling satisfied and feeling that I was in good hands. And yet, if I was 5 stone heavier and I went to the same doctor with knee pain, then unfortunately, it's highly likely that I'd get told to lose weight. And also, it's also likely that I would have delayed presenting in the first place. So my condition would have progressed further before I'd actually gone for treatment. And then I'm not getting the treatment. I'm not getting the referrals. Perhaps I'm not even getting pain management. So above and beyond that, I leave feeling that I haven't been respected. I haven't been taken seriously. Perhaps I'm more ashamed than ever of who I am, of my weight, and also feeling very guilty, all of which are going to send pain through the roof and are going to make self-care very, very difficult. So I think it's that sort of pointing out that, yes, thin people can get knee problems. So there's a lot of reasons why people get knee pain, and it's treating each person in a way that's appropriate for them. It might be that there's somebody who's fatter and they've gone to a doctor who's very haze aware and they've made dietary changes. Perhaps they've got more omega-3 in their diet, and maybe that would help if it's an inflammatory knee pain. Perhaps they're going to appropriate exercise, maybe aquarobics. Maybe they've gone to relaxation classes, that's helping with pain management. The patient and the doctor might still be exploring the possibility that the weight itself could be having some impact on the knee pain. And of course, what we absolutely need then is not to diet. Because if there's ever a possible link between health outcomes and fatness, the last thing that person needs is a diet. That what the patient will benefit from is reassurance from their doctor that they're doing the best that they can for their health, that weight is not something to be made to feel guilty or ashamed of. People of any shape or size who get knee pain deserve exactly the same dignity and respect in treatment, and also perhaps for the doctor to acknowledge the very real challenges of living in a fatter body in a fat-phobic society. If I got onto the bus with knee pain and I was limping, I'd expect to be given a seat. If I was a lot heavier and I got on with knee pain, I'd probably just get filthy looks. And when we have a doctor that can acknowledge that, somebody's lived realities, then that's a really important part of the therapeutic relationship.
How do we help professionals move from scaring to caring?
There's a lot of doctors who are both. They care deeply, and it's their own lack of awareness that puts them also into the scaring category. So when we can combine compassion and critical thinking, then we're onto something. That one without the other isn't going to help.
There's a belief that we need to scare people to lose weight.
And of course we know that it's just nonsense. It's not science. So if somebody thinks that fear is going to motivate change, well, can they show me the evidence on it?